Yeah, so there were, like always, actually quite some questions where we didn't reach consensus. So for example, so one of the really interesting topics, I guess right now is the novel imaging. So the imaging with, for example, PSMA PET CT, so that is actually the focus. And so what are you doing now when you're doing a PSMA PET CT and you see high volume disease? We just discussed that, right? So the subgroups, high volume, low volume. And now in the new imaging, you see high volume disease, but in conventional imaging, you see low volume disease. Are you treating the patient like a low volume disease patient or like a high volume disease patient? And these are the things, because the imaging is quite new, especially in this situation, it was quite 50-50. So 50% of the panelists said, we should treat like a low volume. And 50% of the panelists said, no, we should really treat like a high volume patient. So I guess that is quite interesting, right? Because we know for conventional low volume imaging, because all our studies that we have in the moment, the big phase 3 studies are done with conventional imaging or have been done with conventional imaging. So we know that low volume in conventional imaging, these are the patients who can profit, even in a metastatic situation, from a radiotherapy to the primary. We've seen that in 2 studies, Stampede and Correct. So now, what are you doing now when you see high volume in a PSMA PET CT, right? So these are a bit the questions. And a lot of the panelists were saying, okay, the new triplet therapies, so ADT chemotherapy plus a novel endocrine agent, I would give rather in a situation of high volume. So now is the question, so high volume on PSMA PET or high volume only if it's really also in conventional imaging? And I think these are the areas of non-consensus where we really clearly need new data to help us, to guide us, what should we really recommend our patients.